Hello, everybody. Welcome back. We only have 20 questions more to go, so get that popcorn popping and let's learn the most important content you will need to know by the time you take step one. For our first question, we have a 29-year-old woman presenting to the gynecology clinic for evaluation of primary infertility. As part of her workup, she undergoes a fluoroscopic procedure involving contrast ejection into the cervix to assess the uterine and tubal architecture. Imaging reveals symmetric opacification of the uterine cavity, bilateral narrow linear structures extending laterally. In contrast, materials seen diffusely in the pelvis beyond the tubes. She reports no discomfort. What's the interpretation of her finding? So she is taking a hysterosalpingogram, and it looks like it's showing that there are patent tubes, which is a normal finding. And so the answer is normal finding indicating tubal patency. All right, so the way to think about this is the fallopian tubes are the only direct passage between the inside of the reproductive tract and the open abdominal cavity. Contrast in the peritoneum does not indicate that there is a leak. It only means that the tubes are open. And if they're open, that means they are working. That's how God made them. And it's very common for you to think, oh man, the contrast in the peritoneum, that means there's a rupture. But a rupture would show irregular outlines and also really chaotic extravasation. And also you would be presenting with pain and bleeding. That's not the case here. So in a hysterosalpingogram, or HSG, you have contrast injected into the cervix to evaluate the uterine cavity and the fallopian tube patency. And a normal finding is smooth contour, linear filling of bilateral fallopian tubes, and there should be free contrast spillage into the peritoneal cavity. That would be normal for the fallopian tube. All right, moving on to the next question. All right, for this one, we're going to talk about cholecystokinin, CCK. It's released in response to fatty acids in the duodenum. So it stimulates that pancreatic enzyme secretion, gallbladder contraction, and bile release. Here's our question. An investigator studying a gastrointestinal hormone secretion in response to different macronutrients. On trial, a mixture rich in long fatty acids is delivered. What is observed? The answer, increased cholecystokinin. Fatty acids stimulate CCK release from eye cells. They also might ask you about the sphincter of Oddi relaxation to digest the fats. So the small intestine actually has hormone-sensing cells, and they detect whenever they see fat, and they send chemical instructions to the pancreas and the gallbladder. Increased GIP would stimulate insulin. VIP is for secretory diarrhea. Motilin would be inhibited by food intake. Those are related to fasting and migration motor complexes, so fasting states for motilin. Suppressed gastrin, that would mildly occur with fatty acids, but it's not the main mechanism at play for fatty acids in the duodenum stimulating those CCK. That's CCK release. The goal is to maximize lipid digestion. All right, in our next question, a 24-year-old graduate student is enrolled in neuroscience research examining the neural effects of psychoactive drugs. During the study, she receives a dose of stimulant compound and her brain activity is monitored via functional MRI. The imaging shows increased activity in the nucleus accumbens, prefrontal cortex, and VTA. These findings most likely reflect increased neurotransmission in which pathway? So we have noradrenergic, serotonergic, dopaminergic, cholinergic, and GABA. This is a dopamine pathway in the VTA, and they could make it more difficult and ask which of the dopamine pathways is it? And if they ask that, it's important to know the mesocortical and the mesolimbic dopaminergic pathways are the key circuits underlying drug reinforcement and addiction. And the VTA, ventral tegmental area, projects dopamine to the nucleus accumbens, the mesolimbic pathway. And the nucleus accumbens then projects to the prefrontal cortex, and that's through the mesocortical pathway. So that's the pathway. And that mesocortical pathway to the prefrontal cortex mediates the conscious experience of pleasure and craving and compulsory nature, drug seeking, that kind of stuff. And virtually all drugs of abuse, so cocaine, amphetamines, opioids, nicotine, alcohol, and sedative hypnotics, increase dopamine release somehow in those pathways. Now let's look at why these answers are wrong. Noradrenergic would be associated with arousal, memory, and encoding. Serotonin is mood regulation. It's dysregulated in depression. Cholinergic would be prefrontal cortex associated, attention and learning. GABA is associated with the caudate nucleus, motor inhibition. So once again, it's that VTA that sends the dopamine-rich projections to the nucleus accumbens. That's the pleasure hub. And then it loops in with the prefrontal cortex. So in this student, they're increasing the activation of the nucleus accumbens, the VTA, the prefrontal cortex, and that is why she is feeling the dopamine rush. Now you might ask, why is not an endorphin? Well, endorphins are actually not for step one going to be recognized as reinforcement pathways. Endogenous opioids can modulate dopamine, but they do not directly go through those pathways. The noradrenergic, the norepinephrine through the locus coeruleus, increases alertness and arousal. All right, in our next question, we have, could be a man or a woman, but in this case, it's a 59-year-old woman with a history of hyperlipidemia and diabetes presents to the ED with crushing substernal chest pain radiating to her left arm. She reports increasing frequency of similar episodes in the past, ST depressions in leads 4 to 6. Which the following substance is most likely prevented from binding? Troponin 1 is elevated. She's administered aspirin, clopidogrel, nitroglycerin, and heparin, and an IV medication that inhibits the final step of aggregation. So if it's aggregation, it's going to be fibrinogen, and our answer is indeed C. And for this one, we have to know our GPs. GP2B, 3A on activated platelets is the final common pathway for aggregation because its extracellular domain binds fibrinogen, which cross-links the adjacent platelets. And so abiximab will block the GP2B, 3A and prevent fibrinogen binding, and it also will halt the propagation of the thrombus. ADP to P2Y12 would be platelet activation and upregulation. That is blocked by clopidogrel, not by abiximab. Adenosine, increased CAMP, it'd be anti-aggregatory. And serotonin is released from dense granules. A way to think about this is von Willebrand factor binds GP1B for adhesion, and fibrinogen binds GP2B3A for aggregation. And abiximab is going to block this latter pathway. Fibrinogen allows platelet cross-linking and aggregation. Unstable angina and NSTEMI is what this patient was suffering from, and so they gave abiximab to block that interaction and halt the thrombus growth. Granted, is adhesion. Thromboxane A2 is vasoconstriction and platelet activation, but it's upstream. Serotonin is released from the granules, and ADP stimulates platelet activation. So it promotes that expression, but it does not bind it. So it's the final step in that platelet aggregation pathway is the protein GP2B3A. Next, we have a 6-month-old boy brought to the clinic due to persistent cough, otitis media, and several episodes of pneumonia since he stopped breastfeeding. His birth history is unremarkable. He has no palpable lymph nodes or tonsils. Cytometry shows absence of IgM. Well, it's not going to be hyper-IgM syndrome then. It's going to be X-linked agammaglobulinemia. Flow cytometry shows some normal CD3 T cells and absent or near absent IgMs. Those are B cells, and that would be the classic failure for B cell maturation. And it's these infections that begin after 6 months. And why is it after 6 months? Because that's when the IgG will start to wane from the mother. And the etiology is BTK, Bruton's tyrosine kinase mutation. It's X-linked, and it blocks the pre-B to immature B development. And so you have a very low B cell count and pan-hypogammaglobulinemia. So that would be low IgG, low IgA, low IgM, low IgE. You'll have small or absent tonsils and lymph nodes. And though almost every single time are going to try to make you think that it's something else like SCID, but that would be decreased T cells and B cells. It would have basically a low CD3 positive count as well. And also opportunistic infections would be present. Hyper IgM would have normal B numbers with high IgM, hence the name. Selective IgA deficiency would have normal B and T cell numbers. Only the IgA would be low. And MPO deficiency would be neutrophil killing defect, and the lymphocyte phenotype would be normal. Okay, for this next one, I just wanted to speak very briefly because it's kind of easy. It's just acne in athletes and military trainees. It can be due to friction. You can treat it with retinoids, which decrease the keratinization, benzoyl peroxide, or antibiotics. Here's some myths about acne. And they might say, hey, we have a 17-year-old male who has eruption on his back and shoulders after he's wearing pads during practice. What is the contributing factor? It's mechanical irritation from sports equipment. Acne can be caused by the follicular occlusion, increased sebum production, and then the bacteria gets trapped there. And that's what's happening. It's not the fatty food. And it's not a fungal infection like malassezia, because that would not have the comedones. So yep, you're wearing a helmet, you're playing football, watch out for this. In our next question, we have a 24-year-old woman presenting with concerns about increased facial hair and difficulty losing weight. You should already be thinking of some PCOS, coarse hair on the jawline, and indeed it is polycystic ovarian syndrome. Super easy diagnosis: oligomenorrhea, hirsutism, obesity, elevated LH and FSH ratio. No signs of realization or Cushingoid features, but they do have that kind of facial hair growth, just a tiny bit. They're the trap answers and why they're wrong, but watch out for irregular menses. And also this is due to obesity, which increases the risk of insulin resistance. And you have polycystic ovaries on ultrasound. Androgen secreting ovarian tumor is wrong because they don't have clitoromegaly or deepening voice, and testosterone is elevated, but not dramatically high. Cushing syndrome, that presents with the striae moon facies and the buffalo hump, but you don't see those signs. She lacks central obesity and proximal muscle weakness. Idiopathic hirsutism, it's not idiopathic because the cycles were abnormal. Primary hypothyroidism, fatigue and weight gain and bradycardia and cold intolerance would be seen. And this is actually super common, about 10% of reproductive age women. All right, there are the buzzwords. All right, here's another relatively easy one. A 28-year-old man comes to the emergency department. Look at that, pressure 196. I would immediately start thinking of pheochromocytoma. And so the next step would be start phenoxybenzamine before surgery. Could be a male or a female, as you can see here. Here's an example of a patient. You give alpha adrenergic blockade with phenoxybenzamine. It's non-selective irreversible to prevent the hypertensive crisis. And so there's a triad here. It's paroxysmal headaches, palpitations, and refractory hypertension. If you're put on a beta blocker like metoprolol without an alpha blockade, they're not going to actually worsen the crisis because you get unopposed alpha adrenergic vasoconstriction. This comes from the chromaffin cells, the neural crest cells, and the adrenal medulla. And you should do a 24-hour urine catecholamine metanephrine screen because the metanephrines are going to remain elevated between the attacks. And on pre-op, it's imperative that you do an alpha blocker first, like phenoxybenzamine or doxazosine, and then the beta blocker so you can expand the volume with the fluids. And for the genetics, you should think of men, 2A, 2B, the RET, von Hippel-Lindau or NF1 screen in young patients. So it's episodic catecholamine surges, and you diagnose them with metanephrines, and you have to treat the alpha before the beta, and then you do surgical resection. So you can't give propanolol first or labetalol, even though that has mixed alpha and beta activity. Definitely you cannot observe somebody's pheochrome. You just want to watch somebody die? So the answer is not E. For the next question, we have a 32-year-old man, could also be a female here. Blood pressure 168 over 106. We got a high-pitched bruit in the left upper quadrant. Plasma's renin at 200 on the left and then 12 on the right. We can see some narrowing of the left renal artery. The vasoconstrictor responsible for this is produced where? The answer, pulmonary endothelial cells. And the reason why is because angiotensin 1 is converted to angiotensin 2 by the ACE located at the pulmonary vascular endothelium. And this condition is known as renovascular hypertension from the right renal artery stenosis, like an abdominal bruit. And so what happens is you have decreased renal perfusion, and that causes the juxtaglomerular cells to then release renin. That converts angiotensinogen into angiotensin 1. Then angiotensin converting enzyme, ACE, in the pulmonary endothelium converts angiotensin 1 into angiotensin 2. That's a potent vasoconstrictor that raises blood pressure. And so the vasoconstrictor emerges from the pulmonary vasculature. And so the answer is D. Renal macula densa would be detecting the tubular sodium chloride and signals the cells but does not make angiotensin. Adrenal zona fasciculata, for that you should think of cortisol. Glomerular basement membrane is involved in filtration, and the hepatic sinusoidal endothelium would be angiotensinogen. And so angiotensin 2 is the systemic vasoconstrictor that increases the systemic vascular resistance and preferential efferent arterial constriction. It maintains the GFR. So for therapy here, you do revascularization, angioplasty or a stent. For fibromuscular dysplasia or critical stenosis, you give like an ARB or an ACE inhibitor as well in unilateral disease, but that could also precipitate acute renal injury and bilateral renal arterial stenosis by dropping that efferent tone. All right, for this one, we have a 65-year-old woman with poorly controlled hypertension started on a new medication. 2 weeks later, she reports new onset ankle swelling and occasional headache. Her pressure has decreased from 168 to 130. We have some pitting edema, though, which mechanism explains the hypertensive effect of this drug. Okay, the answer is going to be the decreased arterial resistance, but we have to know the drug. Dihydropyridine, calcium channel blockers act primarily on the vascular smooth muscle. Examples of this would be like amlodipine, and they block the L-type calcium channels in the vascular smooth muscle, and that causes arterial vasodilation, which then decreases the SVR, which is the afterload, and decreases the blood pressure. And it has minimal effect on the heart rate and the contractility, unlike non-dihydropyridines like diltiazem. And these dihydropyridine calcium blockers are first-line antihypertensives, especially in Black patients and those with isolated systolic hypertension, so the elderly. And common side effects can be peripheral edema. And the way that I like to remember that is you think of these as legs, and then you think of this as the edema because it's the L-type. Peripheral edema from arterial dilation, which then increases the capillary hydrostatic pressure. It's not increased capacitance of the venous vessels. Nitrates would work there, not calcium blockers. That'd be venodilation. B, decreased cardiac contractility. That'd be seen with verapamil and diltiazem, not dihydropyridines. Suppression of sympathetic outflow would be a central alpha agonist like clonidine. And reduction of intravascular volume would be natriuresis, thiazides, and loop diuretics. Now, 50 million Americans are treated for high blood pressure, and this is the drug that only targets the blood vessels, not the heart. Dihydropyridine calcium blockers like amlodipine, nifedipine. Heart rate is affected by beta-1 adrenergic antagonists like metoprolol and propanolol. The blood volume can be affected by diuretics. The veins affected by nitrates. But CCBs are antihypertensives that inhibit the calcium influx, and that causes vasodilation and decreased arterial resistance. All right, this one is super simple, so we'll go quickly. An 8-year-old girl is admitted after prolonged exposure to chemical fire in a factory near her home. She develops worsening dyspnea, hypoxia, diffuse bilateral infiltrates on chest x-ray. A novel agent is designed to mitigate the inflammatory cascade. What is it? The answer is interleukin 10. Interleukin 10 is the anti-inflammatory one. And ARDS is a diffuse inflammatory lung injury where you have increased capillary permeability and protein-rich edema, and you have decreased compliance and a VQ mismatch. And that damage is driven by the pro-inflammatory cytokines like TNF-alpha, IL-1, and the neutrophils, recruitment and activation, and also NF-kappa B-mediated gene programs. So IL-10 is anti-inflammatory, and so it helps with ARDS. It inhibits the activated macrophages. It decreases the MHC2 expression, and also Th1 cytokines will be decreased by IL-10. And examples of those would be like IL-2 or interferon gamma. And so it dampens the inflammatory cascade, lowers IL-2, lowers interferon gamma. Now, IL-6 is a acute phase reactant. Interferon gamma is a macrophage activator, so it kind of does the opposite here. GM-CSF would be a granulocyte booster, and leukotriene B4 is involved in chemotaxis. For our next question, we have a 52-year-old woman presenting with 8 months of worsening shortness of breath and a dry cough. She has a 15-year history of Raynaud's phenomenon. High resolution shows bilateral basilar reticulations and honeycombing. Which of the following is most likely the cause of the patient's symptoms? All right, so this is pulmonary involvement in scleroderma. This person has systemic sclerosis, scleroderma. And we know this because they have Raynaud's. That's when the hands turn really white in the cold. And also diffuse skin thickening of the face, the neck, the shoulders, the arms, the fingers. And there's also esophageal reflux and dysmotility, joint stiffness, and progressive dyspnea and a dry cough. And you have dermal collagen deposition. And so the answer to this question, which of the following is most likely the cause, is going to be interstitial lung fibrosis. Because of that diffuse sclerosis, the interstitial lung is the complication. The honeycombing supports pulmonary fibrosis. Answers and why they're wrong. Cryptogenic has subacute flu-like symptoms and patchy alveolar infiltrates. That's not going to be scleroderma. Pulmonary embolism, that'd be super acute, not gradual fibrosis. Chronic bronchitis would have a productive cough. And small cells is a paraneoplastic syndrome, and there's no smoking history here. So pulmonary fibrosis is super serious. It's one of the leading causes of death in patients with systemic sclerosis. So they have skin tightening, Raynaud's, GERD, and a dry cough, scleroderma. It's fibrosis of the alveolar septa, and reticulations and honeycombing will really help you lock in that answer. And this can progress to pulmonary arterial hypertension from the vascular remodeling, but the primary parenchymal process is definitely going to be fibrosis. Now, there's some other answers as well. Like they could have given you emphysema or something that's obstructive caused by smoking. Also, you could see alpha-1 antitrypsin, not fibrosis. They could also try to get you with granulomatous inflammation like sarcoid, tuberculosis, A or GPA, not scleroderma though. Lung cancers like PNA or PE would not match that chronic course. And then bronchiectasis has a bunch of recurrence infections, cystic fibrosis, cartagenars, that kind of stuff. All right, the next question, we have a 62-year-old man, history of chronic tobacco use, presenting with progressive headaches. MRI shows heterogeneously enhancing lesions on the right parietal lobe with surrounding edema. Biopsy shows malignant cells with high nucleus to cytoplasmic ratio. Immunohistochemistry shows positivity of cytokeratin. Very important there. And so what is it going to be then? Well, cytokeratin, and so it's probably going to be epithelial cell. And that probably would suggest a metastatic carcinoma as well. But cytokeratins are the intermediate filaments of the epithelial origin. And the brain mass whose tumor cells stain positive for cytokeratin most likely would be like a metastatic carcinoma. Epithelial would not primarily be like a glial or a neuronal tumor. And so there's some markers that you have to know that I'll write down. Some of the most important markers are for epithelial, astrocytes, mesenchyme, muscle, and also the neurons. So epithelial would be cytokeratin, astrocytes is GFAP, mesenchyme would be vimentin, muscle is desmin, and the neurons would be neurofilament. So epithelial is cytokeratin. So you think of desmin, he's like a really strong guy. Think of your own thing for GFAP. Epithelial, I like to think of that like the keratinization. Neuro with neurons, and it makes it pretty simple to memorize that. So cytokeratin positivity means epithelial derivation. And so if it's a brain mass or something like that, it might be a metastatic carcinoma from the epithelial origin. And that's why the answer is epithelial, even though it's in the brain. So epithelial would be metastatic to the brain. And it's all because of how that's stained, cytokeratin. Smooth muscle would be desmin with the muscle origins. Astrocyte would be GFAP. Endothelial cell is CD31-34. And a neuron, neurofilament. So really, it's just a one-to-one matching game. And it's cytokeratin positivity in this particular question. In our next question, we have a 59-year-old man with a history of mantle cell lymphoma beginning his first cycle of anti-CD20 monoclonal antibody therapy. 30 minutes into the infusion, he develops rigors, diffuse muscle aches, and a fever. His blood pressure and respiratory rate are stable. He has no rash, wheezing, or facial swelling. What is the most likely cause of the symptoms? Well, we got a fever. We got muscle aches after an infusion. So it's going to be a cytokine storm. Okay, so there is our nice man. I actually think I'm going to generate somebody who's like 59 years old. He looks very young. And this is actually something you really have to look out for in minutes to hours, because nearly half of the patients receiving their first rituximab infusion will experience some sort of a reaction, cytokine release syndrome, driven by the B cells. And we know rituximab binds to the CD20 on the B cells, and that triggers their activation. And when they break down, it causes TNF alpha and IL-6, and those guys are troublemakers. They'll cause the fever, chills, muscle pain, but it's not histamine or IgE, and definitely not anaphylaxis. So complement-mediated would be hemoglobinuria and jaundice, mast cell degranulation, urticaria, hives, bronchospasm, IgE activation. Antibody-dependent would be natural killer cells if it's cellular cytotoxicity, if it's cellularly cytotoxic. And serotonin syndrome would cause hyperreflexia and clonus and agitation. All right, so there is the new updated photo for that last question. And now we're already on to a new one. And here we have a 72-year-old woman. This could be a man as well, is undergoing evaluation for persistent fatigue and an unintentional weight loss. Imaging reveals retroperitoneal mass and biopsy shows poorly differentiated cells with high nuclear to cytoplasmic ratios. Immunohistochemistry reveals the tumor cells lack expression of MHC class 1. Flow cytometry of the patient's peripheral blood shows an increased activity of CD56. These lymphocytes are most likely to induce apoptosis of the tumor cells through which mechanism? All right, so the answer for inducing apoptosis is the recognition of cells that lack the MHC1 expression. This is a classic feature of many tumors. And you might say, hey, I've seen FAST and FAST-L that's involved in death. And yes, it's seen in T-cell mediated apoptosis, but not the natural killer cell method. That is a totally different mechanism. Natural killer cells preferentially destroy malignant tumor cells with decreased or absent MHC class 1 expression. That's their whole deal. They're like, you have a passport, you have a passport. Oh, I don't see your MHC class 1 expression, you're dead. That's how it works. IL-2 and interferon gamma secretion, that would be activating the macrophages and T cells, not direct cytotoxicity. And 8086 is the T cell stimulation that's irrelevant to the natural killer cells, which don't have those receptors. And these natural killers are first responders. Basically, you're holding up, every single cell is holding up this thing, the MHC1 that's like, don't kill me. And sometimes these tumor cells, they're being really clever and they just delete that. But then they delete that to avoid detection, but it ends up killing them because the natural killer cells are like, you don't have a passport, and they just attack them. All right, our next topic that we're going to cover is actually going to be an ethics question. You need to make sure you ask open-ended questions and you validate and recognize that emotional states can change, and so you have to check people's understanding. You don't give stats and premature reassurance. All right, so we got a dude, surgical resection. He's like, hey, I finished, but I still feel scared. What should I do now? What do you say? You say, you sound concerned. Can you tell me more about what's worrying you right now? Open-ended is what you need. Can you tell me more? Like, what are you specifically afraid of? That's what you need to be asking in these scenarios. Open-ended questions. If somebody expresses concern, so that you can ask for their understanding, and then you can tailor the discussion according to their gaps and their needs and their concerns. But first you have to ask. By the way, we just launched Ivy Med, which helps you master every major exam. If you want a Harvard tutor who teaches the ACT, SAT, MCAT, USMLE, any of that, then just visit ivytutoring.net. All right, for this one, it's super simple. Burnt sugar odor. That's due to isoleucine metabolism byproducts. You'll see a baby with vomiting, lethargy, hypotonia, 3 to 7 day old infant, onset after feeding starts, branch chain amino acids accumulate. It's an autosomal recessive inheritance, and you get ketoacidosis and cerebral edema because of those elevated branched chain keto acids. There's a deficient enzyme of the branched chain alpha ketoacid dehydrogenase complex that causes these guys to build up, the branched chain ones. And leucine is neurotoxic, so it causes encephalopathy and a coma, and it smells like burnt maple syrup. That's all you need to know for this. So we got a young kiddo, poor feeding, irritability. He was healthy, but now he can't. Now he's got a sweet odor, maple syrup. It's a deficiency in what? Branched chain alpha keto acid. Super simple. One of the easiest questions out there. And that's a cute little photo of that neonate there for that question. Here's some other ones on why they're wrong. Ornithine transcarbamylase would be a urea acid defect, hyperammonia, not sweet smelling. Homogeneous oxidase would be alkaptonuria with a dark urine. Cystathione beta synthase will lead to the marfanoid habitus lens dislocation, not in the neonates. All right, next one, we have a 27-year-old man. I guess we can use this guy. There he is. Goes to the clinic after injuring his right middle finger while rock climbing. He slipped. Ouchies. And he has a sudden pop in his finger. He was gripping and he held it. All right, so now what structure is damaged? This is a memorization one. It's the flexor digitorum profundus. And the way that I like to remember this one is the jersey finger. Because if you're ever playing flag football and you get somebody's jersey, like this guy's rock climbing, and he goes, then you are going to be damaging the flexor digitorum profundus. And it's funny because it seems like a small injury, but I'm like, oh, that was a profound injury. It just helps me remember it. Radial nerve supplies the extensors, not the flexors. Flexor digitorum superficialis flexes the pip, not the dip. Pip, not the dip. See the difference? Digitorum superficialis, and this one is the dip. So superficial. The ulnar is involved in digits 4 to 5 and intrinsic hand muscles. Extensor controls the index finger extension, like that. So high yield MSK, flexor digitorum profundus. There it is, Jersey finger. Yep. You can't flex the dip joint. And now for our last question. We're almost there, guys. You're one question away from watching Futurama or whatever it is you like to do. Walking your dog, who knows, going and working out. 62-year-old woman presents with progressive left axillary swelling for the past 3 months. She denies fever, night sweats, and weight loss. Physical exam shows 3 centimeters firm non-tender lymph node in the left axilla. Excision biopsy shows preserved nodular architecture with small cleaved cells. And we got CD19, 10, BCL2 positive, and monoclonal kappa light chain restriction, and there is no expression of your T cells, CD5, or CD23. Which of the following abnormalities is most likely characteristic? All right, did you get this one right? Do you know what the answer is? So on questions like this, you have a firm, slowly growing cervical node over like maybe 2 months. It's an indolent course. And they talk about maybe on CDs, on the flow cytometry, they talk about CD19 positivity. What's that? That's a B cell. They might also mention CD10. What's that? That's the germinal center marker. And that's actually a hallmark for something. What is it a hallmark for? That's right. For you guys in the back that said it, good job. That, my friends, is the giveaway. CD10 is the giveaway because follicular lymphoma. Light chain restriction is something you could also mention as well. And on histology, you have the nodular follicular architecture. I wonder why. BCL2 positivity. And that BCL2 positivity is actually from the T14 to 18, the translocation. It's the IGHBCL2 translocation. And there we have it, guys. The answer is C, because this person has follicular lymphoma, 14 follicular lymphoma, BCL2 overexpression. Remember that F sound, 14 follicular. Now 11 to 14, 11, look at all those L's. 1, 1, 1, 1. That's how you know that 1, 1, 1, 1 has all the L's because it's mantle cell. Look, 3 L's in that. There are 3 L's in that, and there are 3 1s in this. And that's how you remember mantle is 11 to 14. 814 is a MYC translocation seen in Burkitt's lymphoma. And you remember this because it's mixed. You have a kid who's 8 years old, and you have like an adolescent, and it's mixed demographic there, Burkitt, which would be a rapidly growing mass. And then the 922, for this one, I like to envision a Philadelphia football player wearing a jersey with 922, and that's CML or BALL, not slow-growing lymphomas. And a deletion would be seen in chronic lymphocytic leukemia. So we have a translocation that hijacks that BCL2 gene and it lets them cheat death. They can never die. Which, by the way, I think that humans will get there. I think anti-senescent technology is reaching the point that in my lifetime, there will be some people who are born who won't die for hundreds, if not thousands of years. Wild to think about. That's the importance of getting an education. But yes, I digress. This is follicular lymphoma. It's indolent germinal centers, B-cell lymphoma, CD19 positivity, CD10 positivity, BCL2 positivity, light chain restricted, often is going to be T14-18 translocation. All right, so remember your CD markers. You should be good to go. Congratulations, guys. We did it. Can you believe it? We have finished 200 of these original questions. They're done. If you guys found this helpful, then please share ivmed.net or ivtutoring.net to your friends. We're launching a Step 1 prep course, as you can see here. Now, a lot of this is still in beta, but we have our analytics, we have an entire medical library, and the goal is to make this totally free and extremely cheap for you guys as we continue to add more features. But we're making an interactive medical library with question banks, with flashcards integrated into OnKey, can also plug into other things like UWorld. This is going to be amazing, so visit ivmed.net and visit ivtutoring right here, ivtutoring.net, if you'd like a one-on-one tutor. That's a way that you can guarantee that you'll pass Step 1. You know, it's one thing to just chance it and just study like crazy, which I encourage you to do. Watch all these videos, pass this silly exam. It is a silly exam. It's just a bunch of factoids. But if you really want to make sure that you pass it like 100%, then just visit ivtutoring.net, fill out the form, and we'll give you a Harvard tutor who's going to make sure that you pass the exam. Guys, you're troopers. Thanks for sticking with it. I love reaching out to you guys, interacting with the community. I want to build like a super positive community here. There's some students who email me, which by the way, email me at blake@ivtutoring.net, and they'll say, hey, I just can't do any more studying for the day. And I'm like, no worries. I got to send out some emails. I got some work calls that I got to make. Why don't we just hop on a Zoom call? You can just sit there on the other side and I'll put a Pomodoro timer on and we can just get through this exam. I really deeply care about you guys and I want to make sure that you're taking care of yourself in this prep time. Dedicated period is like crazy. It's not a psychologically like balanced time, and you need to take care of your mental health, your physical health. Make sure you guys are working out. Make sure you're going on runs, taking your dog for a walk. One of the greatest ironies of medicine is that we do too little prepare and prevent and way too much repair and repent. As a future physician, you are sacrificing your mid to late 20s, your early 30s, so that you can help other patients who are suffering. That's very commendable, but don't disregard your health, physical and mental, as you prepare for this test. Remember, if you're struggling, no thought is final. Tomorrow's going to be a new day. You can always reinvent yourself. The only thing we actually have in life is the present. Everything else is either a memory or a best guess about what's going to happen in the future. Reframe those best guesses with cognitive behavioral therapy. Make sure that you self-talk in a way that's positive and try to find a lot of fulfillment as you go through your medical career. Really excited for you guys. Thank you so much for coming along. Thanks for liking and subscribing. If you didn't, thank you for just being out there, for putting in the good work every single day of your life, for helping other people, for showing up today for others and for yourself. Give yourself a pat on the back. And with that, all I'll say is we'll see you in the next video. You guys take care.